All right, everybody, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today is another episode in our Vasopressor series. We've done a whole bunch of episodes on this: norepinephrine, epinephrine, vasopressin, angiotensin 2, methylene blue, hydroxycobalamin, dopamine, levosimendan, all these things. Check out the channel if you're interested in seeing some of those. This one's going to be on Midodrine, and particularly Midodrine's use as an oral vasopressor. We will talk briefly about some of its other uses, but mostly today we're going to be talking about Midodrine in terms of its use as an oral vasopressor. We'll talk about the mechanism action of Midodrine, dosing, pharmacokinetics, indications, both FDA approved and off-label, contraindications, adverse effects, hemodynamic effects, some of the studies and evidence behind Midodrine in this context, clinical practice questions, a high-level summary, and that'll be that. For those of you new to the channel, this channel, Whiteboard Medicine, we do a lot of emergency and critical care medicine content. This is one of many episodes we have on vasopressors, but definitely check out our channel. We got a Patreon page, a podcast, our YouTube channel, all that good stuff. As always, this is not intended to be acted upon as medical advice. Please stick around to the end of the episode for a full disclaimer. It's also located in the episode description. No further ado, let's dive into Midodrine. So Midodrine as an oral vasopressor, we're going to get more into that, but we're going to start with its mechanism of action, some of the explanation behind how it works. So Midodrine is actually a prodrug, meaning Midodrine in and of itself does not do much. It has to be metabolized to its active form, okay? And this metabolization happens in the liver, where Midodrine is metabolized to its active form, known as desglimidodrine. We might have pronounced that wrong. Any pharmacists in the crowd, let us know. Desglimidodrine. And this active form, desglimidodrine, acts as a selective alpha-1 adrenergic receptor agonist. And if you've checked out any of other episodes on vasopressors, you'll recognize some of the words in here, but we're going to go through it. So first is alpha-1 receptor. So the alpha-1 receptor is a catecholamine or catecholaminergic or adrenergic receptor. Those are all synonyms, right? And alpha-1 receptors tend to be part of smooth muscle receptors, and smooth muscle coats our blood vessels. So when the alpha-1 receptor is stimulated, it leads these smooth muscles to constrict, and that can cause vasoconstriction, right? So the stimulation of that alpha-1 receptor causes vasoconstriction, and that vasoconstriction leads to an increase in systemic vascular resistance, which often leads to an increase in the mean arterial blood pressure, the blood pressure in general. So Midodrine's active metabolite, desglimidodrine, being a selective alpha-1 adrenergic receptor agonist, which means it stimulates it, leads to vasoconstriction. All right, so desglimidodrine stimulates peripheral alpha-1 receptors on arteriolar and venous smooth muscle, leading to vasoconstriction. Something to point out here is that it acts on both arterial and venous smooth muscle. So you get both arterial vasoconstriction and venous vasoconstriction, which will come into kind of its hemodynamic effects that we'll talk about in a little bit. So this, as we mentioned, increases systemic vascular resistance, which can increase the blood pressure, the mean arterial pressure. It does not cross the blood-brain barrier, So there's actually no central adrenergic stimulation. For those unfamiliar, adrenergic, this word we keep talking about, refers to kind of catecholamine-based mechanisms of action. So adrenergic, catecholaminergic, catecholamine-based vasopressors are all kind of synonyms. We've talked about in some of the previous episodes that there's kind of two broader categories of vasopressors. There's the adrenergic and the non-adrenergic. And the adrenergic work on catecholamine receptors. These are things like norepinephrine, epinephrine, phenylephrine, and Midodrine. The non-adrenergic or non-catecholaminergic vasopressors have different mechanisms, just mechanisms that don't base themselves on catecholamines. These are things like vasopressin, angiotensin 2, methylene blue, hydroxycobalamin. We've talked about all of these in our vasopressor episode, so check those out if you have more interest. But Midodrine is a catecholaminergic or adrenergic-based oral vasopressor. It does not have any significant beta adrenergic effects, right? There's beta 1 and beta 2 receptors as well. Beta 1 typically increases cardiac output and can increase heart rate, whereas beta 2 actually typically causes vasodilation. Beta 1 receptor effects are present on epinephrine, norepinephrine, but Midodrine does not have these effects. It also has no dopaminergic effects or cardiac inotropic effects, so it really does not directly affect the heart. It indirectly affects the heart, which we'll talk more about, but it does not directly affect the heart. It's a pure alpha-1 agonist. It vasoconstricts the peripheral vasculature without having effects on the heart otherwise. So the net effect here, just to be repetitive, to really drive home the point, is Midodrine causes an increase in systemic vascular resistance, which can lead to an increase in mean arterial blood pressure, and it does not directly affect the heart. So dosing and pharmacokinetics. As we mentioned, Midodrine is oral. This is unique for vasopressors. There aren't really oral vasopressors otherwise. All these other ones we've talked about are intravenous or IV vasopressors. This is an oral vasopressor for all intents and purposes. The oral dose typically used is anywhere from 2.5 to 10 milligrams orally every 8 hours or TID. You will at times see someone go up to as high as 20 milligrams, but most typically 2.5 to 10 milligrams orally every 8 hours or TID, right? 3 times a day. The peak effect occurs within 1 hour after the oral dose. So do remember that this isn't immediate. It's oral. So you got to swallow the pill, you got to digest it, absorb it, and the Midodrine itself is not active, right? It's a prodrug. So you also need to wait for the Midodrine to be converted in the liver into its active metabolite before you see any effect. So you really need to wait 1 hour before you see an effect. The half-life of the active metabolite, the desically Midodrine, is about 3 to 4 hours, which makes sense that we dose it TID or every 8 hours because the half-life is about 3 to 4 hours of the active metabolite. So, that will be, they say, about 5 half-lives before you fully get rid of all the drug, and you dose a TID because that'll be a couple of half-lives, so it works its way out. The bioavailability is fairly good, so anytime you have an oral drug, you're curious how much of that drug that you take is going to be bioavailable. How much do you absorb, right? And the bioavailability of Midodrine is about 93%, so it's really well absorbed orally. You absorb most of the Midodrine that you take in. It's metabolized, as we talked about, in the liver hepatically to the active metabolite desically Midodrine. So if you have severe liver dysfunction, you might not be as able to metabolize that prodrug to the active form, so it might not be as effective. And then you excrete the active form in the kidneys. It's renally excreted. So if you have renal dysfunction, it actually, the Midodrine might stick around a lot longer, and it might start to kind of stack doses because you're not able to excrete that active metabolite through the kidneys because your kidney dysfunction. So there's something to be said. If in patients with kidney dysfunction, continue adjusting the dose in renal impairment because you can risk accumulation. If it does accumulate, you can actually get hypertension, which we'll talk more about down below. So consider starting with lower doses in those with renal dysfunction. So the indications, well, the FDA-approved indication, which is not what this episode is about, is for symptomatic orthostatic hypotension. And this is patients who have kind of autonomic failure. So sometimes you can get atrophy of your neurologic system, or there's other things like diabetic neuropathy that can cause autonomic failure. We're not going to talk much about it here, but some people at home are on Midodrine. Some of you watching this may be on Midodrine at home. And this is what the medication is FDA approved for. But there are off-label uses, and this is what we mostly see in the emergency department or intensive care unit. And the first is this idea, and we're going to get more into this, but that you can use oral Midodrine as an adjunct to try to wean off your intravenous vasopressor. So let's say you're on intravenous norepinephrine at low doses. If you're not doing weight-based, it's something, let's say you're on low single-digit norepinephrine, something like 2 or 3 micrograms per minute, and you've been on it for a little while. The patient's been critically ill for a little while. You think you fixed or are fixing the primary cause of that persistent hypotension, but they've been on these intravenous vasopressors for a handful of days. Some folks will start oral Midodrine with the goal being to try to come off that intravenous norepinephrine so that they're not stuck on this intravenous drug. That sometimes can help you transfer a patient out of the intensive care unit. You don't have the complications of being on an intravenous vasopressor. If your institution mandates that these vasopressors go through a central line, even at low doses, you won't have to leave a central line in because they'll be on oral Midodrine, all under the assumption that the oral Midodrine does help you wean off the intravenous vasopressor, which is a big if. So this is the primary use in the ICU, but there's lots of variability in terms of how people approach this. Some people believe in it and do it all the time. So if you're on low-dose persistent, low-dose norepinephrine, you are fixing the problem. Some people will every time put the patient on oral Midodrine to try to wean them off their low-dose intravenous norepinephrine. Other people don't believe in this, right? Other people think this is the wrong thing to do, and they won't ever give someone oral Midodrine to wean off intravenous vasopressors. So lots of variability here, and there probably isn't a right answer yet. Hopefully more evidence to come in the future that'll help guide us, and we'll go into the evidence that exists down below. Other off-label uses, hepatorenal syndrome, again, not going to talk about it here, but this peripheral vasoconstrictor can sometimes shunt blood towards the kidneys in patients with hepatorenal syndrome who get this persistent vasoplegia. Neurogenic shock or spinal cord induced hypotension. Sometimes these pure alpha-1 receptor agonists like Midodrine can be nice drugs over the long term because you have some degree of inability, some vasoplegia persistent after spinal cord injuries that you might have to be on oral Midodrine. Dialysis-induced hypotension, you'll see this a lot. Some patients have to take Midodrine before dialysis because when they're getting dialysis, their blood pressures will drop. So some patients are on kind of PRN Midodrine to be taken before dialysis. Refractory hypotension in palliative care, we don't really see this as much. We're going to cross that out, not sure what to do with that. Contraindications or caution. So when should you think about not giving Midodrine or being careful with Midodrine? And it's probably not full contraindications, it's probably cautions would be more accurate. When do you want to be cautious with giving Midodrine? Well, severe heart disease, because you're actually increasing afterload. This is a pure alpha-1 agonist, so all this drug is doing is increasing the systemic vascular resistance. So that's increasing the pressure the heart has to pump against. And if you have severe heart disease, this can cause the heart to actually go into cardiogenic shock and start to struggle to pump against that afterload. Acute renal failure, you have to be careful, right? Because doses will accumulate, because as we talked about, the active metabolite of Midodrine is renally excreted. So severe acute renal failure, you won't be excreting that active metabolite. Urinary retention. The mechanism of Midodrine can actually cause sphincter constriction too, so it can worsen urinary retention. So you got to be cognizant of that. If you have a patient who you take the Foley catheter out and they still have persistent urinary retention and they're on Midodrine, this could be a cause of it. And then things like pheochromocytoma and thyrotoxicosis, all these things where a pure alpha-1 receptor agonist can sometimes cause these patients to get worse. You got to be a little bit careful. Other things to think about is supine hypertension. This drug can cause supine hypertension, right? Patients, when they lay down, can sometimes have this severe reflex hypertension when they're on Midodrine. So some people even suggest not giving the drug before a patient goes to bed because that patient will then lay down and can sometimes get this high blood pressure when they're laying down. Coronary artery disease, for the same reason we talked about organic heart disease. Arrhythmias, and this is not all arrhythmias, this is really bradycardic arrhythmias, because Midodrine, since it increases this afterload and does increase systemic vascular resistance as well as mean arterial pressure, sometimes that can actually cause bradycardia. The heart sometimes slows down because the MAP and the SVR have gone up. So any bradycardic arrhythmias, you have to be careful. And then we already talked about renal impairment too. You can get some accumulation in those with renal disease. So One of the big things to take from this is supine hypertension is a major risk, so just be cognizant of that. And some suggest you shouldn't give Midodrine before bed, and that patients should remain upright after dosing for a period of time, although we don't personally tend to go that far. Adverse effects, there's going to be some overlap here. So one of the main ones to think about is the supine hypertension. This is most common, and it can be severe. Those blood pressures can go way, way up. Midodrine can also cause paresthesias, particularly tingling or itching of the scalp and limbs. So that is sometimes something that can occur. Urinary retention, as we talked about, it can cause urethral sphincter or bladder sphincter constriction, which can then lead to urinary retention. This is especially worse in patients with BPH or benign prostatic hyperplasia, men, obviously. It can cause goosebumps and piloerection due to the alpha-1 effects. Piloerection is where the hairs on your extremities stand up. Bradycardia, this is a reflex vagal response to the blood pressure elevation, which is why you got to be careful in giving this in patients with bradycardia. And then rarely can actually cause arrhythmias, usually with higher doses of QT prolonging drugs. This is not common, though, at all. The ones that we feel like we kind of monitor the most for are bradycardia, urinary retention, and supine hypertension are the three that we tend to monitor for the most in the intensive care unit. So what are the hemodynamic effects? If we just summarize all of them, we've kind of talked about them in different sections in here, but let's just get them all in one place. So the main hemodynamic effect is it increases systemic vascular resistance, which then increases the MAP, the mean arterial pressure. As we said, though, it has no effect on the heart because it does not affect beta receptors, which are receptors in the heart, particularly beta 1, right? The MAP and SVR because of the alpha 1 receptor that it affects, but it does not affect the heart. With that being said, though, it does increase afterload, which is what we're giving it for, right? That's the whole point, to increase SVR and to increase MAP, but that can increase afterload on the heart. And by increasing afterload in the heart, it can sometimes cause the cardiac output to go down if it's a patient with heart failure or severe heart disease, right? So it doesn't directly affect cardiac output, but in the wrong patient, a patient who can't tolerate that increase in afterload, it can cause cardiac output to decrease. All right. The heart rate, too, it does not have a direct effect on the heart, but sometimes patients can have a reflex bradycardia that occurs. Okay, so it can sometimes decrease heart rate, although that's a secondary effect, not a direct effect. And then we talked about how alpha-1 receptors affect both arterial as well as venous systems. So it does cause an increase in venous tone, which will increase the preload to the heart. All right, so those are the main hemodynamic effects. Increases SVR, increases MAP, increases preload. No direct effect on the heart rate or the cardiac output, but it could decrease the heart rate through reflex bradycardia and decrease the cardiac output because it has increased your afterload. Hopefully that makes sense. Not too complex, but let us know in the comments if you have any questions on that. What are some of the studies here? Well, the summary here is that there's no right answer here. We don't know if giving Midodrine to help wean off vasopressors is helpful, is hurtful, or what the right thing is. Of some of the studies available, there's one study in 2013 by Levine et al. Published in Critical Care Medicine. It was retrospective, so it was looking back in time at ICU patients that were started on Midodrine during vasopressor weaning. So these patients, someone decided to start them on Midodrine, and then these researchers went back in the charts and looked at the patients that were started on Midodrine. And they did find there was a decreased ICU vasopressor duration, although no change on ICU length of stay or mortality, and then no major adverse effects. So this retrospective study showed that maybe Midodrine does help wean off IV vasopressors, but this was retrospective, and there's lots of shortcomings and biases that can happen in retrospective studies. So there was then another study called the POVER study published in JAMA in 2020. And this was a randomized control trial. So this design was better. These were patients that they randomized from 132 ICU patients who are on low-dose vasopressors. They randomized them to get Midodrine 20 milligrams TID versus placebo. All right. And they found there was actually no difference in time to vasopressor discontinuation, so it did not help wean vasopressors faster. There's no mortality benefit, and there was more bradycardia in the Midodrine group. So their summary actually was that Midodrine did not reduce vasopressor duration and did lead to increased bradycardia. Anytime you see more side effect in a test population, that's always almost a good sign to some degree, because you know that this drug causes bradycardia. So you would expect to see bradycardia, and if, everything else is balanced equal, the fact that the Midodrine group had more bradycardia is actually suggestive that things were well controlled in this trial, because you're seeing the expected side effect in the trial group. So this POVR study was a much higher, still small, right? Still only 132 patients, but it was higher quality than that retrospective study from 2013 we talked about, and there was no difference here, and there's just more bradycardia, so it was not effective in weaning vasopressors. This is another trial on use of hepatorenal syndrome. We'll probably skip that one, but then there was a meta-analyses that have come out between 2020 and 2023, and really the summary here is mixed evidence. We don't know. It seems like it's relatively safe, maybe more bradycardia. It might reduce vasopressor duration in some patients, although it's unclear if that's even true, and there's been no consistent mortality benefit or length of stay benefit in ICU. So unfortunately, the big summary here is we do not know if Midodrine helps us wean vasopressors more quickly or decreases ICU length of stay. It might not. Very helpful, we know. So what are some clinical pearls just in general before we get into the practice questions? Well, Midodrine is not a substitute for intravenous vasopressors in acute shock. Midodrine is not a treatment for acute shock. We want to repeat that. We want to drive that home. Midodrine is not a treatment for acute shock, right? You can consider Midodrine for patients recovering from shock who are on stable, low doses of vasopressors, and you can consider starting it in these patients as a way to try to facilitate ICU discharge or weaning off their low-dose vasopressors. But even this is unclear if Midodrine helps this, right? The studies are unclear if Midodrine is effective for this, but this is the patient population you can consider trying it in. Okay. Consider avoiding dosing within 4 hours of bedtime because of that risk of supine hypertension. Monitor MAP, heart rate, urinary output after initiation, right? This can cause reflex bradycardia. It can cause supine hypertension. It can cause urinary retention. And then for hepatorenal syndrome, it's typically combined with octreotide and albumin, but again, we're not really talking about hepatorenal syndrome in this episode. All right, you guys ready for some practice questions? We're going to have a beginner, intermediate, and advanced question. What we're going to do is we're going to read the question and answers. Then we're going to pause just briefly, and then we'll go to the answer. So if you need more time to think, just pause the episode and then restart it when you're ready to hear the answer. So question number 1, beginner level. What is the primary mechanism of action of Midodrine? A, beta-1 receptor agonist that increases heart rate. B, PDE3, phosphodiesterase 3 inhibitor that improves contractility. C, alpha-1 agonist increasing peripheral vascular tone. Or D, dopamine agonist increasing renal perfusion. All right, pause here if you need more time. The answer is C, alpha-1 agonist increasing peripheral vascular tone. So Midodrine we know is a prodrug. Its active metabolite, though, after it's converted to this in the liver, is a pure alpha-1 receptor agonist, which leads to vasoconstriction and increased MAP. Bonus points. Can anyone think of which vasopressors are beta-1 receptor agonists that would increase heart rate? Lots of them. Norepinephrine does. Epinephrine does. Those are probably two of the bigger ones. What about phenylephrine? Nope. Phenylephrine is a pure alpha-1 agonist. Exactly right. All right, bonus points again. What is a phosphodiesterase 3 inhibitor that improves contractility? Milrinone. Good. Speaking of which, you should have put dobutamine up here as a beta-1 receptor agonist. And what about a dopamine agonist that increases renal perfusion, which isn't really even a real thing anymore? This would be dopamine, which we talked about in an episode, although dopamine is really not used much at all anymore. All right, question number 2, intermediate level. A 72-year-old ICU patient on norepinephrine at 2 micrograms per minute is otherwise stable and ready to transition out of the ICU. The team considers starting Midodrine. Which of the following is the primary rationale for this choice? A, to improve cardiac contractility. B, to prevent further hypotension due to bradycardia. C, to facilitate weaning off IV vasopressors. Or D, to prevent acute renal failure. Pause here if you need more time. The answer is C, to facilitate weaning off IV vasopressors. In select ICU patients, Midodrine has been used to increase SVR and maintain MAP as an oral vasopressor to wean off the IV vasopressors. Right? Evidence, unclear if this works or doesn't work, but this is how it is used. Bonus points. What improves cardiac contractility vasopressor-wise? Norepinephrine, epinephrine, milrinone, which is an inotrope technically, dobutamine, which is an inotrope technically. What prevents further does Midodrine improve or potentially worsen bradycardia? Midodrine potentially worsens bradycardia, so it would not prevent further hypotension due to bradycardia. And then does Midodrine prevent acute renal failure? No, right? Midodrine actually is renally excreted, so in patients with renal failure, it can lead to accumulation of doses that can lead to worsening side effects. All right, last question, the advanced level. A 58-year-old man with decompensated cirrhosis and rising creatinine is oh, we forgot we made this hepatorenal syndrome. Apologies. Well, bear with us. If you all want an episode on hepatorenal syndrome, let us know. A 58-year-old man with decompensated cirrhosis and rising creatinine is diagnosed with hepatorenal syndrome. The ICU team plans to start albumin and octreotide. What is the rationale for adding Midodrine in this setting? A, to increase splanchnic vasodilation and improve liver perfusion. B, to reduce aldosterone-mediated sodium retention. C, to increase systemic vascular resistance and improve renal perfusion. Or D, to stimulate renal dopaminergic receptors. Even though we didn't talk much about HRS, you could still get this question just based on what you know about Midodrine. All right, pause here if you want more time. The answer is C, to increase systemic vascular resistance and improve renal perfusion, right through that alpha-1 receptor agonism. In HRS, Midodrine counteracts the systemic vasodilation that happens with cirrhosis and helps redirect perfusion to the kidneys. Good job. So in summary, Midodrine is an oral alpha-1 agonist. It is a prodrug that is converted into its active metabolite in the liver. In the ICU, it is sometimes used as a bridge to get off low-dose stable IV vasopressors. The typical dose is 2.5 to 10 milligrams orally 3 times a day. Some people go up to 20 milligrams orally 3 times a day. The peak effect does not occur for 1 hour, so you got to be patient. It can cause supine hypertension. It can cause urinary retention. It can cause paresthesias. Be cautious in patients with renal impairment as it is excreted in the urine. So those with renal dysfunction, it can accumulate. And evidence for its effect as a bridge to wean off vasopressors is very limited. Moderate is too strong here. We're going to say weak evidence. Cool. That's all we have for you today. Let us know what thoughts, comments, questions you have down below. Check out our other episodes either on our YouTube channel or podcast feed. If you want this study guide, it will be on our Patreon page. We also have more practice questions on there. And then if you want early access to things as well as some other benefits, we also have a YouTube members page as well that you can join. Either way, stay well, keep learning. We hope to see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.